Thank you, Stuart. Good morning, everybody. So the learning objectives for my talk are going to be to understand state-of-the-art protocols for imaging IBD. I will then compare the different protocols, where to use what, and we will go a bit into imaging the colon, but I have to say in our institution most of colonic imaging is over to the gastroenterologist. They do endoscopy, so we're only doing like one-stop shops, and I will cover on that. So, to warm up a bit, what are the challenges in inflammatory bowel disease, especially Crohn's disease? It's an asymmetric mucosal inflammation, and it's transmural. It's any part of the GI tract, and 80% of all patients have an involvement of the small bowel. It's unpredictable, relapsing, and it's remitting. So you never know what you have and where it is. And the first peak is among young people. There's a second peak about 60 years old. So if we look at the consequences for imaging, we have these things that we really should address independently from the modality you use. So you have to image the entire bowel wall for the transmural part of the inflammation. You have to cover the complete abdomen so that you are sure that you don't miss any other points that could be involved. And then, since it's relapsing, when you image, you have to look at the activity of the disease. And since many people are really young, whenever possible, don't use ionizing radiation. So let's get into first of that. Imagenologia said, imaging small bowel is like looking in a reptile tank with a large number of writhing snakes. So to separate one small bowel section from the other, it's really important to have distension. So you really should look that the small bowel is not collapsed. Now, there's the classical technique, enteroclysis, where you use a tube, you put it into the small bowel, ideally into the proximal jejunum, and give contrast there. But again, you use ionizing radiation. If you only do enteroclysis, it's a 2D display, and it's very unpleasant for the patients to have that obtained. What we do in our institution is we let people drink, so the enterography. It's 2.5 or 25 gram mannitols. This is a special sugar which is non-resorbable, and it doesn't get digested. So you can really use it as an osmotic, hyperosmotic thing. It's over an hour, about 1 liter to 1.5 liter. And we started with about like 40 or 50 grams and are now down to 25, because the higher you get, the more you have the problem with diarrhea. And when people are in the magnet with urge, that's not very good for the patients and for the MR. So there's plenty of different possibilities to do this non-invasive distension. There's only water, there's diluted barium, especially in the United States, volumin. There's polyethylene glycol, locust beam gum, metamucil. There's also always a big discussion about the difference between enterography and enteroclysis. What to use when. There's also a discussion about, do we really need distension to fill up the tube that it's getting stretched? Or do we need distension to separate one side of the bowel wall from the other side, which are two separate things, actually. If you ask the patients, I think it's quite clear that they prefer to drink. Again, if you need the intubation, it uses ionizing radiation. If you look at data, it's quite interesting on the side that if you compare peros and enteroclysis, especially at the terminal ileum, there where it should be most important, you don't have a significant difference between the two. Again, there are two different papers, and both of them didn't find a significant difference if you use enteroclysis or enterography at the level of the terminal ileum. So, to cover the entire abdomen, I just wanted to use that to look a bit at the different techniques. So, if you use ultrasound, again, the patient should fast for 4 hours. There are no special preparation, or you can let the patient drink. There are different aspects. If you let them drink, use water, mannitol, not this much as you would need for the slice imaging, and you would need to have the curved and the linear probe, transducer probe, to look at the different sections. I think to really look at the bowel wall, you will need a high-resolution linear transducer. It's also important, if you have the possibility, there's strong data about the use of contrast-enhanced studies, but you always will have the problem that you're not going to be able to cover everything, and that's still a problem with ultrasound. If you do CT, it's more or less an abdominal CT. That is the protocol that we use. It's more or less a normal standard abdominal CT, again, with the preparation for the distension. It's also possible to do a CT enteroclysis. Again, you have the enteroclysis part, and then you have the CT phase. In the enteroclysis part, you really place the catheter, you don't give the contrast, you put the patient into the CT or into the magnet and apply the contrast. The problem is, in MR, you can check how far the contrast is with a heavy-weighted thick slab T2, and then you know now it's time to start. With enteroclysis, you will not be able to do that, because every time you do that, it's another scalp. So, in MR, whenever possible, we lie the patients prone, an IV line. This is our protocol that we use. I think most important is we have a motility sequence to start with. It doesn't move. There will be some movement later on. So we have a sinetrophism sequence. With this, we do the motility sequence. We cover the complete abdomen in breath hold, one after the other. It's not so long. Every breath hold sequence goes about 20 seconds, 15 to 20 seconds. And every breath hold the slice is about 6 millimeters to 10 millimeters. So the coverage, especially when they lie prone, they will be compressed by their own weight. So it's not that you have motility images for 15 minutes. The next is going to be a haste sequence, axial, and then there's the contrast sequence, which is very important from my point of view. And we do it dynamically, so without contrast, and then 30, 60, and 90 seconds. We have like timestamps that we really can look how the contrast is behaving within the different sections of the small bowel. Now, if you do colonic imaging, there's no change. That's how we do it. There's no change in the preparation, in the distension of the small bowel. So these patients drink 1 to 1.5 liter, and then they go into the magnet and they will get an enema. Pure water, I would say, warm it up a bit, because it's very uncomfortable if you use cold water, and do it slowly. If you fill up the colon too fast, patients getting cramps and they will have pain. So do it slowly, looks like this. And there's another good thing you should use is wrap them up in plastic that if anything happens again, you don't have the whole thing within your magnet. So, determine activity of disease. I will go too much into that. I think Jaap will cover that afterwards. This is the way we do our film reading. And so we look at the T2, we look very good at the T1 contrast enhancement, at the wall thickening. What I would focus on is if you compare CT and MR, and if you look at the data, you have to say for mural changes, there's a good and high accuracy for both, but it's clearly stronger for MR. And this is not so difficult when you look at the possibilities not only to have one series of contrast enhancement, so you have different series of contrast enhancement, and you have the T2 imaging. Again, for stenosis, there's a very high accuracy for both imaging techniques. Again, for disease activity, there's a good accuracy in CT and clearly a better accuracy in MR. If you look at fistula, abscesses, both are very clearly established method where you could use. There are, and this is a big but from my side, there are clear advantages technologically that you could use for MR imaging. One of them, as I said, is the dynamic contrast enhancement. If you look at the difference between normal small bowel and inflamed small bowel, and today there are even papers that you can separate between fibrotic parts, acutely inflamed parts, and normal parts, just with the dynamic. So the dynamic contrast enhancement is a very important thing for determining disease activity. There's diffusion imaging, which is more a bit like in research, but still there are ways to do diffusion imaging that helps you. And then, now it's moving, motility. I know it's one of our research focus, but there's clear things. If you look at motility, it correlates with histopathology. It correlates with the degree of activity and with the degree of chronic changes. And I think this is clinically very important, it really helps you to detect more lesions. These little skip lesions somewhere else, you see bright spot and you focus on them, and if you look at the motility and you see, okay, this one is obvious, clear, and then you see regions where it doesn't move and you go back to the classical or standard imaging, you will find additional lesion. And this is, I think, the most important point for clinical use, that it helps you to find additional lesions. So, when to use what? I think whenever possible, and I think this is the key point, whenever possible, use MR. There are for sure moments that you cannot use MR. This is night emergencies, or if the patient doesn't tolerate to stay for like 30 to 40 minutes in a magnet. For sure, it's if Crohn's not even known yet, that these patients will have most of the time their first CT, and then you assume it could be Crohn's. Everything else, the primary tool, the workup, especially the follow-up, and I think we are getting more and more of these patients that the gastroenterologist calls you and say, I think this patient needs an MR. He has a diffuse abdominal pain, and we don't know what's happening. We know he has Crohn's. And this leads me to the last point, spare ionizing radiation. There's a paper in Gut where they looked at the radiation exposure of people with Crohn's. And the mean exposure of these patients was 36 millisievert, and over 15% had an exceed over 75 millisievert exposure, just because every time they came in, they said, oh, Crohn's needs an abdominal CT, and they get their abdominal CT. So whenever possible, and that brings me, this is my personal idea, how to try to reduce. If there's a follow-up study, I think there shouldn't be much discussion that whenever possible, try to find a slot in MR. When there's an emergency, when the patient comes over the emergency room, or he's in somewhere in the ward, then try to find out how bad it is with ultrasound. And if it's not working, try to find a slot in MR. Really try to help these people to omit CTs whenever possible, because you will be the one managing the dose for these people. And if it doesn't work, like during the night, and it's very important, then you go for CT. But try also to stimulate the idea with your surgeons, with your gastroenterologists, that it's very important that these guys don't get every time a CT. So, this is something like an executive summary. So for imaging the entire bowel wall, think about distension. There's enterography and there's enteroclysis. I think most of the centers do enterography right now, but there's still some room for enteroclysis. Cover the entire abdomen. I think nevertheless, it's easier with CT and MR. Do multiple phases whenever possible, and think of that MR has many more possibility than CT to really get, especially the problem with the disease activity. So what you should get out of your technique is bowel wall thickening, think of contrast uptake, and look for the extraluminal problems. And, as I said, use ultrasound or MR imaging whenever possible to spare ionizing radiation. Okay. Thank you very much.